We are very excited about the program. I think we have stellar speakers trying to get cutting-edge knowledge on advances in hepatology. And we don't want to keep you any longer because we know we have a very dense program. And I think across this spectrum of basic science advances, technology advances, innovation, translation, and then implications for clinical management and for future management, I think this is the scope where we see the meeting.
The session is, I think, a very, very hot topic in hepatology. So it will span from monitoring liver disease progression to pathway of care. And we are really very happy to have outstanding speakers today. And I welcome the first speaker of the day, who is Professor Maja Thiele from Odense in Denmark. She is professor of medicine there, and she's an expert in non-invasive assessment of liver disease. And she will tell us about if we need a non-invasive liver health check in the general population. Welcome, Maja.
Thank you so much. So to begin with, I think for the question, do we need a liver health check? Well, we do have a global, very good basis for unhealthy livers. So this is just showing the rate of obesity across the globe and the global per capita consumption. And I think especially in the high-income countries, alcohol is a real problem. When you translate a per capita consumption of 9.2 liters of pure alcohol into average drinking, it actually corresponds to each and every adult age 15 or above drinks on average 14 standard drinks per week. That in my book is a pretty big amount. And I haven't even shown the global burden of chronic viral hepatitis in this slide as well. But moving a little bit from kind of the global population scale, I want to just dive into the single individual. What can detection of liver health do for the person? So this is John. He was a guy participating in one of the screening studies we conducted in Odense. So he's an average Dane, 55 years, slight overweight, no metabolic comorbidities, but his main reason for approaching us was that he had been drinking in excess of around 5 standard drinks per day since his spouse died a couple of years back. Now he had quit drinking and was very motivated to be investigated for alcohol-related liver damage. So we conducted an ultrasound, hyperechoic liver, concordance with steatosis, but otherwise no sign of chronic liver disease. Normal biochemistry, but still a FIB4 slightly above the 1.3 threshold. And when we then conducted liver stiffness by FibroScan and the ELF test, both were significantly elevated in concordance with a compensated liver disease, compensated advanced chronic liver disease. So what happened then? Well, this was really an additional motivation for John. So when we saw him 6 and 14 months later, he continued to be abstaining from alcohol. And indeed, at the 1-year investigation, the liver stiffness had dropped significantly to only 12 now and an ELF of 10.2. No decompensation when we saw him. And indeed, at follow-up to this day, he had not experienced any liver-related events. However, his BMI has increased, so he's now in the obesity category. So how did John benefit from a liver health check using, in this case, FibroScan and ELF test? Well, this increased his long-term motivation to remain abstinent. He did indeed improve his nutritional status despite gaining weight. His albumin went from 40 to 48. Had let's say, an early liver disease detection. Indeed, there's a better tolerance to any pharmaceutical and non-pharmaceutical interventions. We did conduct the screening endoscopy checking for varices because his liver stiffness was in the range of clinically significant portal hypertension. He was followed in the outpatient clinic, and indeed, if it had been today, he could be eligible potentially for resmetirom or semaglutide if we deem that his any liver disease progression is now mainly driven by obesity rather than alcohol. So just as an example of the individual benefit. But for the next question is then, if an individual benefits from a liver health check, should we expand to do liver health check screening? So would that be considered screening? And I think for screening, we should distinguish between mass screening and targeted screening. So in mass screening, you screen the general population. Anyone is subjected to a liver health check. With targeted screening, you only look for those at-risk groups. But both forms of screening require a very standardized setup with standardized information, standardized protocols and procedures for how to handle those. With a positive screening test, it needs to be not just a one-off screening, but actually repeated, similar to what we see in national cancer screening programs. So for that, I think screening with a liver health check is far too immature yet for the liver space. There's also the risk of screening when you are not only detecting cases, but you really want to show that screening actually reduces liver-related morbidity and mortality. And in this, screening is really like a logical danger, because I know this graph is a bit complex, but imagine a patient like John and you have disease progression. Now, if we detect disease early by screening, but we don't do anything about the natural history, so the progression in the individual who are detected just continues as it would without screening, we introduce lead time bias. So lead time bias is the time from early detection to the time of symptomatic detection, where we would otherwise have detected the patients if we had not screened. And so the lead time bias leads us to perceive an increased survival time only because we are pushing the diagnosis to an earlier time point. But the only way screening will work is if we at screening are actually able to modify the disease course. Otherwise, it just looks like we have an increased survival time, but it is really due to lead time bias. Also, there's ample evidence from cancer screening of negative consequences of screening, both psychologic and somatic negative consequences, but also overdiagnosis. Again, in steatotic liver disease especially, patients die from many other causes than liver disease. So even though you may detect the liver disease, if the patient dies from other causes, this is overdiagnosis. Screening programs also tend to favor inequality in health because, in essence, those who are in less need of screening, the most affluent part of the population, they tend to go to the screening program, while those who actually need the screening the most, the least affluent, those of the lower socioeconomic stages, they tend to not go to the screening programs. And finally, to actually be able to know whether screening works or not, we do need a randomized trial looking at whether screening reduces liver-related morbidity and mortality. And this trial has not been performed. So I think we can talk about a liver health check, but we don't talk about screening yet because it's simply too immature. We need to plan ahead. Now, the second question I want you to think about is liver health. What is that really? We tend to talk a lot about fibrosis and non-invasive markers of fibrosis. And indeed, as you can see here from Hannes Hagström's group, my colleague in Stockholm, the fibrosis stage, especially those with advanced fibrosis and cirrhosis in MASLD, indeed predicts both all-cause mortality in the top and liver-related events in the bottom. But liver health is so much more than fibrosis. Again, we are not discussing chronic viral hepatitis, where presence of virus may be a reflection of unhealthy liver. I discussed with Vincent Wang and other colleagues yesterday how just presence of excess fat in the liver is not a sign of liver health in opposition, even though it may not be a single prognostic marker. And indeed, as shown here, even those just having elevated AST as a marker of hepatic inflammation has a poor prognosis in terms of cumulative risk of liver-related events. So the liver is so exciting because it's a complex organ, and therefore when we are discussing liver health, we shouldn't be so naive as to think that liver health is just absence of advanced fibrosis or absence of fibrosis. Liver health is similarly a complex feature. We may, however, still consider investigating liver health in the population, and I want to just highlight today this very elegant publication also from the Swedish group. The core algorithm was just published, and here it's the Amoris cohort, which is a cohort of lab tests stemming all the way back from the 80s and then followed up for several decades. The core algorithm is a machine learning model containing only ALT, AST, GGTH, and sex. And they were able to classify patients into those at highest risk of cirrhosis or progression to cirrhosis within 10 years and those who did not progress to cirrhosis within 10 years. And as you can see here, in those with a predicted risk of 1% or more, 57 of those who developed cirrhosis had a predicted risk above 1%, while 0.4 of those who did not had a predicted risk above 1%. But please note that it's still only 1% risk of liver-related events. So this means that if you have a core score of 1%, you still have 99% chance of not developing symptomatic cirrhosis within 10 years. And indeed, if you transform these 57% and 0.4% into actual numbers, it's very clear that the minority of those with a core score of 1% or above, namely 759, indeed developed events, while the vast majority did not develop cirrhosis. So the ability of any risk score to detect and prognosticate in a general population where the prevalence of cirrhosis is very low and the risk of developing symptomatic liver disease is super low is minor. So we need to lower our expectations of a general population liver health check. So what can we do instead? Well, the easy thing is to target people with risk factors, and in this case for steatotic liver disease, I won't go into the viral hepatitis screening. And one can, for example, look at alcohol and abdominal obesity as two major risk factors for liver disease, and especially when the two appear in combination, it is a potent cocktail, so to speak. So in one graph, you can see data from the FinRisk cohort in Finland, where those with a high waist-hip ratio and only moderate drinking of one standard drink per day had a significantly higher hazard ratio, and it was actually comparable to those without abdominal obesity drinking 4 units per day. Same with diabetes, where both the diabetes itself and the alcohol use has a summaric effect on the risk of liver-related events. So what can you expect if you start doing liver health checks in patients with at risk for liver disease? Well, these are data from Odense, where we screened more than 3,000 people one-to-one into either having alcohol as a risk factor, prolonged alcohol use for at least 5 years, or metabolic dysfunction, regardless of whether they were drinking currently or not. And you see across this at-risk group, we by biopsy detected a little less than 2% with advanced fibrosis or cirrhosis. I should mention that we offered a biopsy to all those with liver stiffness above 8 kilopascal. and elevated liver stiffness above 12 kilopascal, which is a widely agreed prognostic indicator of a little less than 4%, and especially in those with a historic use of alcohol, this was high. When we classified them according to the SLD nomenclature, especially those in the ALD group, this is no surprise, had a very high prevalence, and this is unselected, only selected on risk factors, so not from primary care, not from secondary care. Still 7.5% with biopsy-confirmed advanced fibrosis. And indeed, across all three categories of steatotic liver disease, MASLD, MED-ALD, and ALD, the number of cardiometabolic risk factors also predicted the proportion with elevated liver stiffness above 8. So combining history of alcohol use, present alcohol use, and cardiometabolic risk factors, not only as a binary, but actually as the number of cardiometabolic risk factors, will increase the pre-test prevalence of advance of fibrosis, and thereby increase your chances when doing a liver health screening of actually finding those at the highest need of detection while avoiding overdiagnosis. I won't go too much into the different types of markers. There have been a flurry of non-invasive tests. I am personally in favor of those tests that can be incorporated into laboratory information systems. A lot of the tests that are being published, you need BMI or you need type 2 diabetes, which is let's say a challenge if you want to incorporate them into your lab information systems. Many countries have FIB4 incorporated. FIB4 is better than nothing, but it suffers both from poor sensitivity and specificity. Liver risk score is one of the newer multivariable markers. It has copyright control, but it can be accessed from an online calculator, while if you want something that has gone through IVDR regulation, so the European in vitro medical device regulation, you need some of these commercially available tests. So with that, I want to highlight a few take-home messages. So first message is, fortunately enough for us who have an interest in the liver, it is a complex organ. So liver health is also a complex definition and cannot be defined by a single measure. If you do liver health check in an unselected population, you may detect the 1 to 5% at the highest risk of liver-related events, but even within these high-risk people, the minority will ever develop liver-related events. And indeed, most events will still happen in the lower 90% of the population. So it is more appropriate to check liver health in at-risk populations where you can have a higher, even though it's not super high, but still a higher prevalence of significant advanced fibrosis and risk of progression to liver-related events. And I truly believe that the way forward are non-invasive blood-based markers, because those can be incorporated into the existing systems that primary care use for secondary preventive actions. And this opens up for true scalability and true integration by integrating the liver health check into other routine health checks. And with that, I thank you very much for listening. And I don't know if we have time for questions, but thank you anyway.
Thank you very much, Maja. This presentation is open for questions, so please go to the microphones. I see Frank Take, please.
Yeah, thank you, Maja. A fantastic presentation, makes you think a lot. But I was wondering whether you're a bit too pessimistic, because like in your individual, you showed that you actually did intervene very early on. And I was wondering, even if you detect this liver risk, you at the same time detect a higher cardiometabolic risk, cardiovascular risk. So even if you don't prevent the cirrhosis, or we will never be able to show that, an early intervention on the lifestyle and keeping your liver healthy could do a lot of benefits on the larger scale.
Yeah, that's an excellent question. Thank you for that. Well, I'm very inspired by the cancer screening programs when trying to parallel screening for a non-communicable disease like steatotic liver disease, for example, and then cancer screening. And I think the big difference here is if you detect a colon polyp, you can remove it, and then you have removed the risk of cancer development in that precancerous polyp, right? But lifestyle factors are so much more difficult to remove than a precancerous polyp, right? And so from other fields, cardiometabolic fields, there have been randomized studies done also in Denmark trying to intervene against elevated blood pressure, high triglycerides, all of these metabolic dysfunctions that we know very well. And what these randomized trials show is that it is so difficult. So while I'm able to show a very nice story about a patient that was already motivated for lifestyle changes, I should say, before he even entered our observational screening study, when you look at the randomized trials, the effect is actually non-existent. It is very, very difficult to change people's behavior. However, with the new obesity medication, this may very well change because now there's a very effective pharmaceutical intervention for these metabolic dysfunctions. But again, we would need a randomized trial to actually prove an effect on, and I agree, not just liver-related events, but overall cardiometabolic events. Because, again, a lot of this mortality is driven by non-liver-related mortality. And again, if we can benefit the patient and avoid them having a stroke, they would be very happy for that as well, even though we as hepatologists may be disappointed that it was not a ascites, right?